Welcome to this module on wound care in the urgent and emergent care setting. During this module, we will go over some wound healing principles, initial wound management, deciding when to close a wound, and antimicrobial selection. Welcome to the Master Course on Urgent Care, brought to you by KRUUSE. Let's start by talking about wound classification. Wounds are broken down into four main categories: clean, contaminated, contaminated, and dirty or infected. Clean wounds are those that are atraumatic and surgically created under aseptic conditions like your general incisions for surgery. A clean contaminated wound suggests that there was a minor break in aseptic surgical technique, like controlled entry into the gastrointestinal tract during foreign body removal. The contamination here is minimal and easily removed. Contaminated wounds are recent wounds that are related to trauma with bacterial contamination from the street, soil, or oral cavity. If a wound is associated with a broken bone, this is called an open fracture, and these are classified as follows. Grade 1 means there's a small break in the skin, usually less than 1 centimeter, caused by the bone penetrating through inside to out, and the surrounding soft tissue has mild to moderate contusions. Grade 2 is soft tissue trauma of greater than 1 centimeter that's continuous with the fracture itself, often caused by external trauma like a bite wound, so big dog, little dog fight, or open fractures associated with jumping out of a moving vehicle. Grade 3 means that there is extensive soft tissue injury, often in addition to high degree comminution of the bone, like you would see with a lawnmower injury or high velocity gunshot wound. Next, let's talk about the 3 phases of wound healing: inflammation and debridement, proliferation, and maturation. These phases do not occur independent of one another, and overlap is often present. Inflammation happens within the first 5 days of injury immediately after trauma. It is secondary to disruption of blood flow, followed by constriction of the vascular bed and accumulation of platelets to clot the area and limit bleeding. These platelets then release a lot of growth factors that help to bring other cells to the area that are required for wound healing, such as neutrophils and monocytes. The accumulation of these cells initiates the debridement portion of this phase. Neutrophils are the first to appear in the wound after approximately 6 hours of injury. They cause debridement by removing extracellular debris through enzyme release and phagocytosis. Monocytes show up a little bit later, approximately 12 hours after trauma, and then become macrophages within 24 to 48 hours. Monocytes are pretty helpful in that they stimulate fibroblastic activity, collagen synthesis, and angiogenesis. As the monocytes go into their cool phase as macrophages, they remove necrotic tissue, bacteria, and foreign material. The proliferative phase of wound healing then begins about 4 days after injury and lasts about 2 to 3 weeks. This is the most dramatic healing phase and is characterized by angiogenesis and granulation tissue formation and epithelialization. During this time, fibroblasts proliferate and start synthesizing collagen, and the capillary beds grow to form granulation tissue. Wound contraction is noticeable by about 5 to 9 days after injury and continues into the maturation phase. Last but not least, the maturation phase occurs once adequate collagen deposition is present and is marked by wound contraction and remodeling. It starts at about 17 to 20 days after injury and may continue for several years. It is important to note that healed wounds are never as strong as normal tissue, and scars are only about 80% as strong as the original tissue bed they came from. When you have a patient presenting through the urgent care center with a wound, it's important to find out as much information about It is important to find out as much information as possible about how the wound happened and thoroughly evaluate whether the patient is stable or unstable at the time of presentation. This includes the primary survey, where we look at cardiovascular, respiratory, and neurologic function. You should definitely be wearing gloves anytime you're examining a patient with an open wound. And if any excessive active bleeding or drainage is present, this should be addressed first and foremost. For example, if you have an open laceration on a distal hind limb with active arterial bleeding that is not controlled with either a bandage or continuous pressure, did you know you can actually place a tourniquet for up to 1 hour on the leg? You can manually make your own, use one that's supplied by a company, or you could be creative and actually use a blood pressure cuff and inflate it up to 200 millimeters of mercury and hold it there in order to act as a tourniquet. You also want to evaluate the extent of the wound. It is not uncommon for bite wounds to penetrate into the abdominal or thoracic cavities if they're truncal in location. If bite wounds are down on a limb and you only see them on one side, it's recommended to clip and clean the other side in order to see if you can find the corresponding wound marks. This is also important when you think about gunshot wounds. If the bullet goes in on one side, ideally it has to come out on the other side or it's inside the patient. It's always important to shave the opposite side of the chest, limb, abdomen, whatever area of the body in order to find out if there is an exit wound on that side. Wounds should always be kept clean and moist and protected from the hospital's environment. You can apply a sterile, water-soluble lubricant and saline-soaked sponges to the wound initially, and then cover it with a sterile towel and bandage if the patient needs to be moved or manipulated. It is also important to prevent the patient from contaminating the wound themselves. KRUUSE offers a great selection of Elizabethan collars to use for patients in the hospital setting. Most recently, they have released the Green Ocean Collar. The Green Ocean Collar from KRUUSE was launched on Earth Day in the US, and it's the first collar that is made from recycled ocean plastic fishing nets. Once a patient is considered stable enough to undergo continuous wound manipulation and sedation or anesthesia for wound care, you can proceed with one of the most important steps in wound care, which is debridement and lavage. The primary goal when you're managing a wound is to create a healthy wound bed with a great blood supply that's free of dead tissue and infection in order to promote appropriate healing. Some wounds are straightforward and can be closed pretty easily. However, some wounds require daily debridement and bandage changes for up to weeks and sometimes months. Therefore, don't get discouraged if you look at a wound initially and it seems really daunting and can't be closed immediately. You can accomplish amazing things with wound care like tie-over bandages and pressure vacuums. When debriding and cleaning a wound, first apply sterile lubricating jelly to the exposed wound tissue to protect it from further contamination, and then clip a very wide area of fur around the wound itself. Any gross dirt that's on the skin should then be cleaned by applying a surgical scrub solution like chlorhexidine or iodine to the unbroken skin. But make sure not to come in contact with the wound itself, as these solutions can be very damaging to exposed tissue. It is also important to remember that iodine does not work in the presence of organic material. Therefore, any dirt that's on the skin should be cleaned off, and you can use iodine to do that, but then you should make sure that you're continuing to sterilely prep the skin once that organic material is gone. Debridement should be done aseptically using sterile gloves, a sterile gown, and a cap and mask, and the wound should be draped sterilely as well. Once you are scrubbed in and prepped, you want to look at the wound and remove as much necrotic and dead tissue as possible. Any bite wound should be explored to see how far it tracks under the skin, because teeth create a macerating and crushing force that can damage tissues deep below the skin surface. After removing dead tissue and exploring the wound and manually removing obvious large pieces of dirt and debris like leaves or sticks, the wound can be lavaged with a variety of solutions. Isotonic solutions like lactated Ringer solution or 0.9% saline are the most commonly used lavage solutions. One study did show that using normal saline and tap water could cause mild and severe side effects on the wound cells, where this did not happen with lactated Ringer's solution alone. Therefore, you could consider starting with just LRS or just 0.9% saline, but water alone or water mixed with those should ideally not be used. The wound is lavaged by flushing with a bulb syringe or a 60 ml syringe with an 18 gauge needle or catheter attached. You can use a 3-way stopcock connected to an IV fluid bag for rapid filling of the syringe, particularly if you need to lavage a large volume. The wound should be lavaged until all superficial and deep material and debris has been completely flushed out, including all hair, dirt, leaves, road debris, or anything else you see that appears foreign. If the wound is 12 to 24 hours old, uninfected, and small enough that it can be closed by primary closure, closure can be performed at this time. However, if the wound is greater than 24 hours old and clearly necrotic or infected, it should be left open for continued tissue declaration and serial debridement. It can take up to 72 hours, or sometimes even a little bit longer, for wounds to declare themselves fully, and a wound that is closed prematurely can create significantly more complications for the patient in the future. Following debridement and lavage, any wound not being closed by primary closure should be bandaged. The bandage consists of 3 layers: primary, secondary, and tertiary. The primary layer is the dressing directly applied to the wound and will be either an adherent or non-adherent dressing. It may also include a topical antimicrobial agent like silver sulfadiazine or Manuka honey. An adherent dressing is used in the debridement phase of wound healing and provides mechanical debridement by physically pulling away dead, damaged tissue and debris. An example of this is the wet to dry bandage. A wet to dry bandage involves soaking lap sponges or a similar material in a saline solution and then wringing them out. They are then placed directly on the wound and covered with dry sponges or gauze. The bandage then has string tied over top of it to create a sealed environment. The purpose of this bandage is to physically pull away debris from the tissue as the bandage dries. These wet to dry dressings can be very, very effusive and sometimes need to be changed multiple times a day. They also can potentially cause the wound to dry out. Either way, you need to keep a very close eye on them. Non-adherent dressings are exactly as they are named, non-adherent. This means they don't stick to the wound and therefore don't pull away tissue at the surface level of the wound. Examples of non-adherent dressings include alginates, foams, hydrogels, hydrocolloids, Manuka honey sheets, which can actually come in adherent and non-adherent forms. The benefit of non-adherent dressings is that they keep wounds moist through all phases of wound healing. Therefore, once you feel that your wound is properly cleaned of necrotic tissue and debris, and you see healthy granulation tissue forming, it's time to switch your dressing from adherent to non-adherent. Frequency of bandage changes can often be decreased at this time as the wound is not drying out as quickly. The secondary layer of the bandage is then composed of padded material that aids in absorption of exudates. The tertiary layer is the outermost protective layer that holds the other 2 layers in place. KRUUSE provides 2 options for the tertiary layer of the bandage. The VetFlex bandage material is a superior quality cohesive bandage for fixation of dressings and controlled support of sprains and splinted fractures. It's strong, comfortable, user-friendly, and comes with a dispenser box for easy storage. It also comes in pretty cute patterns, if I do say so. The Chew Stop bandage is a cohesive bandage, and it's the anti-chew version of the VetFlex bandage. It comes in a handy red color to help distinguish it from the VetFlex. I also like to use this red color bandage for marking other lines and catheters on the patient. A tie-over bandage can be used as an alternative for wounds on areas of the body that are not amenable to a soft padded bandage, such as the flank, perineum, or hip area. All bandages should be protected from the patient and external environment with judicious use of e-collars and appropriate bandage coverings when walking patients in and out of the hospital. If a patient initially has poor mobility and is at risk for soiling their bandage, consider short-term placement of a urinary catheter to prevent the wound and bandage from becoming soiled. Large wounds that are not able to be closed immediately have a couple of options for closure, including closure once the wound is healthy and granulation tissue has started to form. This is typically performed 2 to 5 days after bandaging of the wound and is classified as delayed primary closure. Secondary closure is closure of a wound 5 or more days after the inciting injury. Second intention healing is healing of a wound on its own without surgical closure or manipulation and is selected for very large wounds or wounds where tissue manipulation does not allow closure, like on a limb. It is important to be very upfront with owners about the expectation for wound closure, especially as larger wounds that are being closed by second intention can sometimes take weeks to months of serial bandage changing before the wound is considered closed. This will be a huge time and financial investment for owners. It is also recommended to consult with a surgeon with any large wound being closed by secondary closure or second intention. Large wounds might also require negative pressure vac therapy, aka a wound vac. This should ideally be performed at a tertiary facility under direct supervision of a board-certified surgeon or veterinary critical care team. The last aspect of wound closure to consider is whether or not to place a drain in the wound. Drain placement is indicated during wound closure in areas with excessive dead space or pocketing where fluid can accumulate and form a seroma, or in areas where there was previous infection like cat bite abscesses, or following surgical exploration for penetrating foreign material or drainage tracts. The drain should exit at the dependent portion of the wound via a separate stab incision, not through the suture line itself. The drain can then be removed when drainage is clear or minimal. We also want to institute antimicrobial therapy as soon as possible for any open wounds. This should ideally be done after the initial debridement and lavage, so you can get an appropriate culture sample prior to starting antibiotics. Source control is extremely important for preventing infection of the wounds and preventing them from progressing to a systemic infection. The most common bacterial wound pathogens include gram-positive Staphylococcus species and Streptococcus species, and gram-negative organisms such as E. coli, Enterococcus, Proteus, and Pseudomonas species. The most common anaerobic isolates in bite wounds include Bacillus species, Clostridium species, and Corynebacterium. If you have access to a gram stain kit in your hospital, it can be very helpful when assessing infected wounds on presentation to help guide antimicrobial selection. Superficial wounds in systemically stable animals can typically be treated with broad-spectrum antimicrobials such as cefazolin or cephalexin, pending culture results. If the wound is deeper and at a higher risk for infection, or is largely contaminated, you also might want to consider an even broader spectrum antibiotic such as Unicin, which is a potentiated amoxicillin. Published recommendations for severe bite wounds state that they should be treated with a potentiated amoxicillin with either the addition of a fluoroquinolone or an aminoglycoside. Given the increased risk for acute kidney injury with the use of aminoglycosides, it is more common to reach for fluoroquinolones in this case. Patients should be kept on the same antibiotics, and the antibiotics should ideally only be changed if necessary based on culture and susceptibility results. That said, if you have a patient where the wound is not healing or progressing after the first 2 to 3 days of treatment, or where the animal's condition is worsening, you could consider a change in antimicrobial therapy at that time. Once mature granulation tissue has become established, antimicrobial usage is usually considered unnecessary. Topical antimicrobial drugs are commonly used to decrease bacterial populations on the wound, but they should always be used in conjunction with debridement and lavage. Silver sulfadiazine cream has a favorable broad-spectrum bactericidal coverage and is the agent of choice for burn wounds. Moist wound healing is a proven practice that creates an optimal environment for wound recovery. By maintaining the right moisture balance, it promotes faster healing and enhances the overall healing process. Here are a few of the incredible benefits that come with using KRUUSE Manuka honey. Up to 50% faster healing has been seen with the use of this Manuka honey. Patients experience expedited healing times, allowing wounds to close and mend more rapidly. This Manuka honey also promotes debridement. The honey's natural properties aid in the removal of dead tissue, promoting a clean and healthy wound bed. KRUUSE Manuka honey provides optimized cellular growth. The honey creates an ideal environment for cells to grow and regenerate, supporting the body's natural healing processes. With KRUUSE Manuka honey infused into non-adherent acetate gauze, you can say goodbye to painful bandage removal and minimize discomfort during dressing changes. The honey's healing properties contribute to less scarring and improve cosmetic results, giving you peace of mind. An example of this is a German Shepherd that we had recently that had an abscess form on the inside of her leg. We've been using KRUUSE Manuka honey sheets on her for the last 6 weeks. We've never seen a wound heal that quickly or contract the way that hers has. In fact, it's been healing faster than another patient where we've not been using those Manuka honey sheets. Next, let's talk briefly about some additional wound management modalities to consider, such as hyperbaric oxygen therapy and low-level laser light therapy. Hyperbaric oxygen therapy involves placing patients in a chamber that replaces room air with 100% oxygen under pressure. It works by increasing proliferation of fibroblasts and increased leukocyte oxidative killing of bacteria. Low-level laser light therapy uses low levels of red and near-infrared light to penetrate tissues and increase energy production at the tissue bed level, as well as to increase activation of fibroblasts. Both of these are great options for alternative wound care therapies. This concludes this module on wound care in the urgent care setting. Please move on to the next module whenever you're ready. Thanks!